Muy bien, pues vamos a empezar. Muchas gracias a los que se conectaron puntual. Es para nosotros un honor este primer webinar que tenemos con Cutera directamente para México. Y qué mejor de la mano del doctor Andrei, quien tiene mucha experiencia ya con AviClear y otros equipos de Cutera. Así que muy contentos de recibirlos. Vamos a empezar la sesión desde el punto de vista de un KOL. Él está en Canadá. Vamos a conocer un poco más del futuro de los tratamientos de acné. Thank you very much, Dr. Andrei. It's a pleasure to have you and welcome and hope to see you soon here in Mexico City.
All right. Well, buenas noches, everyone, and thank you so much for spending your evening with us and inviting myself. I wish I could be in person in Mexico City, but here I am in Canada. It's quite nice, but I'm sure not as nice of a weather as where you guys are situated. But of course, a very warm welcome, and once again, thank you to also Cutera for helping facilitate this discussion and for inviting me. I think we have several Cutera members all the way from US, including Caitlin, on the line. So I was asked today to give you some of my personal experience when it comes to AviClear, a laser from Cutera that is specifically designed and approved for the treatment of acne. And so in order for you to just have a sense as to who I am and what kind of practice I have, and maybe it'll resonate with you guys as well. I'm a trained dermatologist. I have a very large practice in Canada, in Calgary, Alberta. I work with a number of other dermatologists and family physicians. So we have over 40 staff in the clinic. We see on a daily basis over 350 patients, which constitute both medical patients as well as cosmetic patients. And many of our medical patients, in fact, all of our medical patients necessitate a referral because to see a dermatologist in Canada, there is very few dermatologists. You need to be referred to see us. And inevitably, as part of our referral, we see a tremendous number of patients who have acne as a concern. But we also have a large cosmetic practice because that is what my fellowship was in. I was in Boston, where I trained in aesthetics and laser and cosmetic surgery. We have over 30 different devices from a variety of companies, of course, Cutera being one of our preferred partners. And we always try to combine the treatment of whatever skin condition we have with every possible state-of-the-art device, if there is such a thing. And traditionally, when it came to acne, most of our acne patients necessitated some form of acne scar treatment. And so for years, I've been utilizing laser resurfacing. But today, we will talk about the treatment of acne with devices, which is AviClear. And just to give you a sense, I think it's really important for those of you who are dermatologists, and I understand most of you are from all over Mexico. At the end of the day, we have a lot of skincare providers and a lot of clinicians. But when patients are asked, who do they trust? They do trust their dermatologists, specifically with skin recommendations. In particular, as you can see on this slide, 3 out of 4 patients ultimately trust their dermatologists. But despite the fact that they trust their dermatologists, they also wish that their dermatologists would educate them and explain to them all of the available treatments, in particular in-office treatments, such as lasers, which are available to them. And I think there is a disconnect between what the patients want and what we as dermatologists are able to provide, because some of our colleagues, either because they do not utilize lasers, or in the case of maybe AviClear, they don't have enough of the knowledge and information about it, are unable to give that very information that the patients want in an understandable and simplistic manner. And so those same patients then end up going to sources which are not as precise, like online or social skin influencers, and sometimes might get the wrong form of education. So hopefully through today's discussion, and feel free to ask me questions either during or after, we can come up with some kind of an algorithm or paradigm as to what kind of patients can benefit from laser, while at the same time remembering that we have other treatments as well available, in particular when it comes to acne. And so when I'm asked what excites me about AviClear, is the fact that we, for the first time in the history of acne, actually have a device that can selectively treat acne. And while it might sound very intuitive, a laser that treats acne, I can tell you that even when I was doing my fellowship, which was almost 16 plus years ago, this intuitive understanding of the ideal wavelength of acne was very difficult to make into actual practical consideration because it took a very long time, as we'll discuss today, to come up with a specific wavelength and then build a machine that is easy, simple to use, safe, and also applicable to a variety of patients to actually make it happen. So that's what excites me about AviClear specifically. Now, what's also very useful for us to understand is this device, certainly in United States and in Canada with FDA and Health Canada, is approved or cleared for all kinds of acne. So it's not just the moderate or severe. You can see that basically you have a blanket statement, even from the regulatory body, as to the kind of acne you can manage. And notice the word long term. Again, we're not talking to physicians or my experience, we're talking about regulatory bodies that really scrutinize the evidence. So the fact that in this case, Cutera was able to get a clearance for a long-term indication is actually quite remarkable. Because as we know, when we manage acne, even with our conventional medical treatments, long-term is a big deal because our patients can flare, they can get recurrence of their lesions. So that by itself is impressive. The way the treatment is designed is you typically space 3 conventional treatments, usually 1 month apart, and we'll show you how this treatment works. Here you have an illustration of the actual machine and the handpiece provided, but ultimately what this treatment is targeting is the sebaceous oil gland, the origin of acne. And as we try to understand the etiology of acne, I think sebaceous oil gland, certainly in North America, has come back into its resurgence or etiology with the approval of one of our topical anti-androgen therapies, which I know is available in Mexico as well, which goes by the generic name of clascoterone or the therapeutic name of Winlevi, where we were once again reminded that if we can target the sebocytes or the androgen receptors on the sebaceous oil gland, we can potentially obliterate many of the steps that induce acne from happening. But just to give you a little bit of a background and history, when it came time to actually develop this device, the engineers who were in charge of, in this case, Cutera device, had to ensure that 3 principles were targeted. The principle number 1 is obviously efficacy. You have to build a machine that works. How do you build a machine that works? Well, by default, to have a laser, you need to have a specific wavelength. And so those of you who know Rox Anderson, kind of the godfather of laser therapy, would perhaps remember that one of his mentees at the time, Fernando Sakamoto, together with him, a few years prior, has published a paper that actually solidified the idea that the ideal wavelength to target sebaceous oil gland was somewhere in the range of 1720 nanometer. And so, as I'll show you in subsequent slide, the wavelength of 1726 represents an ideal target for sebaceous oil gland that's very precise and specifically where there's a greater absorption by sebum as opposed to water, almost in a 2-to-1 ratio. So we have the wavelength. The second principle when it comes to efficacy is making sure that you have appropriate thermal relaxation time. And this goes all the way back to lasers. And so if we recall, the thermal relaxation time of a sebaceous oil gland is usually in the range of about 60 nanoseconds. 60 milliseconds. So you have to have pulse width that's shorter. And so the fact that we have a pulse width here, which is 50 milliseconds in the device, respects the principle of selective photothermolysis, which is so important to once again ensure that we have a very targeted therapy. So that works. So we have the right wavelength, we've got this right pulse width, we also have to ensure that the device is powerful enough. And so if you look at the metrics of the device, for those of you who are very interested, you'll see that it's a very powerful device. It's a diode-based device that has a power of about 100 watts. And again, this power ensures that you generate sufficient amount of energy or temperature to actually shatter the sebaceous oil gland and prevent any production of sebum or any subsequent steps in acne. So that is principle number one, efficacy. But we also have to respect two additional principles. Principle number two is safety, because just because something is efficacious does not automatically imply that you're not going to burn the skin. And so specifically, when it comes to heat and the origin of the sebaceous oil gland, we have to be very protective of the dermal epidermal junction. And we know from previous studies that if the temperature within this junction reaches greater than 50 degrees Celsius, then by default, you can get all the complications. And specifically, you can get burns, erythema. In darker skin patients, you can get secondary pigmentation, etc., etc. So how do you protect the superficial layer of the skin while at the same time creating that optimal destruction of the sebaceous oil gland? And this is where this proprietary contact cooling comes in, which Cutera is so good about because they have other devices where they've already developed it, including, for example, XLV and XLV Plus. And so by having the contact cooling, you're able to actually mitigate and protect that DE junction on one hand, while at the same time being able to still generate the appropriate heat within the actual sebaceous oil gland. That has been shown, obviously, in their initial papers, white papers that were presented at various laser meetings. And furthermore, if you look really close at the actual tip of this handpiece, you'll notice that there's specific sensors. And so those of you who had an opportunity to use this device will realize that you can only fire the device if all of the sensors are perfectly representative of the full contact within the skin. So there's a safety mechanism implied as well. So that's parameter number two. Parameter number three is patient comfort, because you can have the most efficacious device in the world. You can have a device that's safe, but if it's painful, if it's poorly tolerated, then of course our patients will refuse the treatment. And pain is sometimes related to heat. And we know that there's also specific temperature parameters, not just from a safety standpoint, but from a pain standpoint. And usually we talk about a temperature parameter of approximately 42 to 45 degrees Celsius. And so again, if we can mitigate that heat by keeping the pulse width relatively short, and also by having all the cooling in place, pre-cooling, intra-cooling, and post-cooling, post the treatment cooling, then it will ensure that the patients will tolerate it. So as I present the data, I want you to remember all three of these parameters: the efficacy parameter, the safety parameter, and the patient tolerability, which will be reflected in the clinical studies. Now, just to show you how the device actually looks, I'll show you first the actual Cutera video that they have developed, and it's a very easy treatment to represent. And then I'll show you one of our personal videos that we did in the clinic when I just got the device. So a very ergonomic device. You can see a patient and a provider in this case. The patient's skin usually is cleansed with acetone, specifically to decrease the skin. The provider usually wears the protective goggles as shown here. And you have a very specific, very user-friendly display, like many of the modern Cutera devices that specifically allow you to dial in all of the parameters that we'll talk about specifically. You have a hexagonal spot size, which essentially is a 10 millimeter spot, but the device also gives you an opportunity to do micro spots, which is 3 millimeter spot size, for example, for a touch-up. And you can see that on average, the patient will get approximately 300 pulses. So in many instances, that will imply that you will use the treatment in multiple directions. This is an example of me doing this treatment in our clinic.
Hi guys, Dr. Metelitsa. As you can see, we're using our new acne laser, AviClear laser, specifically to treat facial acne. It's very exciting. We just started using this protocol. Here it comes.
And you can see the sensors ensure that you can only fire when the laser handpiece is in full contact with the skin. And you can also appreciate that there's a little bit of a cooling effect that's even visible before the firing, during, and of course after as well, which once again ensures that safety, but also the tolerability of the device. Now, I know I'm speaking to dermatologists, so this is going to be redundant, but just to reiterate that this is not all about device, we actually understand the principles and the pathogenesis of acne. We know that acne develops at a certain age, and it's usually during puberty. And so that is why it's so important to once again recognize that acne is a hormone, or in this case, androgen-dependent condition. It's been well identified that there is androgen receptors which are present on the sebaceous oil gland. We know that we have some medical therapies that potentially can target these androgens. Perhaps some of your patients might be on an oral contraceptive. Perhaps some of your female patients might be on an oral anti-androgen like spironolactone. I certainly use it in my patients. Usually my dose is 50 to 100 milligrams. And more recently, we are also combining the topical that I already mentioned, clascoterone, which, although it's a slow onset product, can also help by theoretically blocking the androgen receptors on the sebaceous oil gland. And it's those very androgens that trigger inflammation and subsequent sebum production. And like every dermatologist can explain in this room, you subsequently have follicular hyperkeratinization with formation of whiteheads and blackheads, the comedones, subsequent perfect milieu or perfect soup for proliferation of virulent C. acnes, because not all C. acne are virulent. And once you have the pathogenic proliferation of C. acne, we have subsequent inflammation, and as a result, all of the clinical features of acne that we know so well as dermatologists. And like many of you, I utilize medically a combination of numerous treatments. We have topical retinoids, the original retinoids, the new generation retinoids, including what we have in our jurisdiction, topical tazarotene lotion, which is now known as arazlo lotion, triferritine, the fourth generation retinoid, known as a cleave cream, which specifically targets the gamma receptors on the skin. And of course, all of the novel combinations that may or may not be available in your jurisdictions, including bivalent and even more recently approved trivalent topicals, such as combination of clindamycin, BPO, and also adapalene. It's known as Captrio gel. I mentioned some of the oral agents. Of course, we also can combine oral antibiotics, and we also use isotretinoin extensively. I've given more than 5,000 isotretinoin prescriptions to my patients. But as we discussed, for a variety of reasons, patients seek light and laser-based devices. Sometimes they have already failed all of those treatments, and oftentimes these treatments are just not enough. So over the years, there's been a tremendous push to utilize device-based treatments. And as many of you recall, initially, those utilized some of the well-known infrared and even RF-based devices, but by them not being specific to the sebaceous oil gland, they not only were as targeted and as efficacious, but were associated with concomitant side effects, so they were not perfect. At some point, many of us started to utilize blue and red light therapy to capitalize on porphyrins, and in particular, photodynamic therapy, also popularized by the Harvard group. But once again, it wasn't the best treatment, and it often, at least in my hands, would cause acne flare. It's sometimes very significant, so not very well tolerated. So the fact that we have now a laser device, a selective device, that can kind of treat acne at its pathogenic core by distracting sebaceous oil gland is very advantageous because it can basically block this entire process. And this laser capitalizes on this diagram Because if you look at the difference between absorption of sebum and water, you will notice on the left-hand side that there's a very narrow wavelength, specifically at that 1726 nanometer wavelength, where the absorption coefficient for sebum not only outweighs water, but in fact outweighs water in a 2-to-1 fold configuration. So at any other wavelength, if you were to design any other laser, it would not work because it would not target sebaceous oil gland. And that is why I can assure you that for many years to come, regardless to which other device we'll ever talk about, when it comes to sebaceous oil gland, the wavelength that makes sense is this one. And that's why Cutera has the device specifically with 1726. And on the right-hand side, you can actually look by individual numerical scores within that 1700 to 1750 range. And once again, you can see that that perfect peak, the optimized selectivity, is exactly at 1725 to 1726 wavelength. That is the wavelength that makes the most sense based on everything we know about absorption of sebum. And we also understand histology, because what actually happens to the sebaceous oil gland? And that's been well studied in the initial pivotal studies that were published by Goldberg and colleagues, specifically with the Cutera AviClear device. On the top, you have a healthy representation of a sebaceous oil gland. And at the bottom, you have a magnified view of what happens after the patient has had a treatment with AviClear. Essentially, what we're all seeing is necrosis of the sebaceous oil gland. And I should add the word irreversible. So it's not like it's going to recover back to normal. You're actually damaging that sebaceous oil gland. And by default, you're preventing whatever process of acne to happen as a result of that damage. You can induce miniaturization of the sebaceous oil glands as well, but we can see that there's still a number of sebaceous oil glands that will be preserved. So it's not an all or nothing process, but it definitely will diminish them sufficient enough to lead to clinical response that we'll talk about. And this is where the clinical paper comes in. We have Alexiadis and Arminicus, together with colleagues, publish a pivotal study on AviClear, where they looked at 104 patients across 7 investigator sites, specifically looking at the treatment response in acne. And it's really important here to understand the patient population. So these patients were at the age of 16 plus, and they had the entire spectrum of acne. You can see, and I'll show you more specifically, all the way from mild to severe inflammatory acne, with a number of lesions listed here. And they were followed by a standard 3-treatment protocol. But what's so important to note here is it was performed as monotherapy, which is not necessarily what I do in my practice. I often combine things, and I'll mention that. But in this case, to really facilitate the understanding of clinical efficacy, this was done as a monotherapy. And most importantly, note that there was no pain mitigation. As you recall, my third principle was patient tolerability. So the fact that there was no concomitant pain mitigation, no pills, no laughing gas, no Penthrox, is very important for us to note. The endpoint that was chosen was a reduction by at least 50% in inflammatory lesions as a primary endpoint. But of course, there was some exploratory points listed here on the right-hand side. Now, I already mentioned that they had a diversity of age on the left-hand side, starting with the age of 16. And as we know, we have a variety of acne patients. Looking at my own practice, although I see a number of teenagers, I do have a lot of adult female patients referred to me for acne, whether medical therapy or laser. And it's certainly reflected in this patient population as well. You can see that a proportion of patients were over the age of 26. But what I found most interesting is even though the inclusion criteria were all the way from mild to severe, most of the patients were actually not mild. Most of the patients had moderate to severe acne, which is also very useful for us to note because intuitively, many of those patients traditionally would necessitate some form of systemic therapy. I mean, as soon as a dermatologist hears moderate to severe acne, you automatically start thinking either combination of maybe an antibiotic plus some topical retinoid compound, or at some point you start thinking about isotretinoin, your Accutane-based products. We also really need to point out that this was a very diverse group of patients. You know, if you're a dermatologist for any indication and you look at clinical trials, sometimes the limitation of the study, especially if it's done in North America, is it only includes Caucasian patients. And so it might not be applicable to my practice, where, as many of you know, Canada is a very diverse practice. So clinically, I see patients with Black skin, Asian skin, patients with East Indian skin. So we see the entire variety. And it certainly is very important for those of you in Mexico, because by default, your patients are not necessarily going to be type 1 and type 2 skin. So the fact that we have a very even representation of skin types, I think, is very helpful to apply to our clinical practice interpretation. And this is a very important slide. So the primary endpoint, or the response rate, was accounted for the following number of weeks after the last treatment. So at the bottom on the horizontal axis, you see the number of weeks. And so when week 4 is listed, what this actually implies is 4 weeks after the last treatment. So if they had treatments on a monthly basis, every 3 to 4 weeks, then by default, week 4 on this diagram would actually imply month 4 after the start of the treatment. And going all the way to week 52, when you see that parameter, that implies that this assessment was done 1 year after the last treatment, or in essence, 1 year and 3 months after the first initial assessment or the initial treatment of the patients. And so what we see here is not necessarily what we would expect. And this is what I have noted in my own clinical practice and what I now incorporate in my clinical education of the patients, which is done by both myself, but also my cosmetic consultants, my nurses, and my surrounding staff. We tell patients that they might notice an improvement after even the initial laser, but most of them will start noticing an improvement about 3 to 6 months after the last treatment. And this is precisely what this graph shows. Look, 1 month after the last treatment, only 30% of the patients had a 50% reduction in inflammatory lesion count. It's impressive, but it's not absolute. But look what happens as you move into week 12, 26, and 52. Not only do you have stability, but you have a very visible exponential progression or improvement of the patient's lesions. So if you see a patient and you do 3 treatments of AviClear, and the patient comes back to you and they say, you know, doctor, I like the laser treatment, but I'm just not seeing the improvement that you promised me or that I anticipated, the short answer is we have to wait. We're not going to see an instant gratification with this device in all of those patients. You might have super responders, which is reflected by the 33% at week 4. But most of our patients, which is what we typically do when we counsel them, we have to think about averages. Most of them will take time. But by year 1 after the last treatment, the majority of the patients, in fact, nearly all of them, will have a 50% reduction in inflammatory lesion count. And that's certainly now reflected by my clinical practice as well. Now, another way of looking at it is an absolute reduction in lesion count. So that's why in this case, the graph looks down. So this is the absolute median inflammatory lesion count and percent change. So you can see the percentages listed here at the bottom of the graph and the absolute lesion count noted within individual dots. And again, 1 month after the treatment, you'll have approximately 38% reduction in absolute lesion inflammatory count. By 1 year after the 3rd treatment, you've got 80% reduction in inflammatory lesion count. Once again, demonstrating a very impressive efficacy response. And so those of you who maybe want to compare this, for example, with some of our topical therapies, I can remind you that when it comes to reduction of these things with topicals, we typically do not see numbers greater than 70% with topical therapy. So this is certainly supersedes all of the topicals that we have in our clinical practice, and it rivals many of the systemic agents as well. When it comes to efficacy, it's also important in parallel to consider safety as well. And so that was my third parameter that I told you about. We talked about efficacy, safety, and patient comfort. And so this kind of reflects both of those things. So the safety, the second parameter, is listed here. So all of your patients will likely get a little bit of redness and a little bit of swelling. But look at it, at the bottom in the text, it actually shows you that it's very transient. It usually lasts for hours or at most couple days. I cannot think of a single patient in my practice where we use the device on a daily basis nearly, where you've had persistent of redness for longer than a couple days. So it's certainly not an issue. The third one listed here is acne flare-ups, and I can tell you it's real. We know that that's often the case with many of our treatments. In fact, if you use isotretinoin in your patients, you're well familiar that the proportion of our patients in the first month will sometimes get an acne flare-up. And so as dermatologists, we even sometimes start our patients on lower doses, or in extreme instances with systemic therapy with isotretinoin. Sometimes we even have to combine it with prednisone in anticipation of that acne flare-up. Well, we don't necessarily see it to the same extent with laser, but with AviClear, you will have a proportion of patients that perhaps after the first or even after the second treatment will get a little bit of a flare of acne. And the reason this is so important is, again, in your counseling, if you tell your patients what to anticipate, then the chances of complaints or uneventful phone calls or things that nobody expected will be significantly diminished. And if it doesn't happen, then we have an extremely happy patient. So I tell all of my patients that there's a possibility of an acne flare-up. But again, do I see 40% of that happening in my practice? I would say that my practice is less, maybe 25%. Some patients experienced a little bit of dryness and itchiness, but I certainly do not view it as a clinical concern. And I can't really, frankly, think of too many of my patients that have this, despite the fact that Calgary, if any of you have visited, is a very dry place, a very dry city. But of course, in my hands, all of our patients are concomitantly encouraged to use moisturizing cleansers and in fact moisturizers just as part of their daily skincare routine, and the fact that I'm a dermatologist and I educate them. Now, notice a very important line at the very bottom: no treatment-related hyperpigmentation observed. And this is especially important for those of you who are well-versed in the treatment of lasers, because by default, we know that when we have patients with darker skin, and when we use any kind of laser for any indication, there is always a higher risk of post-treatment hyperpigmentation. You know that with non-ablative laser resurfacing, you know that with ablative laser resurfacing, it can happen with your vascular laser kind of treatments, etc. So the fact that there was no hyperpigmentation noted despite the diversity of the patients, once again, reflects this significance and the ability of this laser to be so diverse in its treatment parameters for a variety of patients. In fact, you can use the word colorblind in a sense, because this laser is colorblind and can be used for all of your patients. And you'll see examples of my personal practice. They say a picture is worth 1,000 words. So these are the pictures from the original clinical trial, where you have patients from all different skin types before and after. And in this case, all of the photographs were taken 6 months after the third treatment, or in other words, 9 months after the baseline before the initiation of the first treatment. So you can see that these patients range not only in skin types, but also in severity. For example, the first patient on the left-hand side, which is Fitzpatrick 2, it's a female. If you look at her skin, I would grade her as a moderate to severe inflammatory acne. that's the kind of patient that we start thinking systemic therapy. Again, maybe a combination of doxy and one of our topical agents, or alternatively, potentially even isotretinoin. And yet look at her improvement. She mainly has a little bit of macular erythema left. Then we can discuss how to treat it. But in essence, she got a systemic-like effect, perhaps even an isotretinoin-like effect, without the need for any systemic therapy. And we see a very similar kind of presentation on the right-hand side in your patient that's listed as Fitzpatrick type 4, where you have a more inflammatory type of presentation, almost cystic-like acne, and it's even more pronounced on the bottom in Fitzpatrick skin type 6, your last patient, where despite having both darker skin presentation, black skin, and multiple inflammatory lesions, you're noticing a significant improvement. So I think certainly from a clinical trial standpoint, this device performed exceptionally well. And that's what made it so exciting for myself. And so I was fortunate to be one of the first practitioners in Canada to have it in my practice. And we've now had it for nearly 2 years. Now, in real life, we don't have to follow protocols. And so I can tell you from the beginning that I utilize this device in all kinds of patients. I use it in diverse skin types, but I also use it as a combination therapy. And frankly, all of the things that I have listed to you as monotherapy treatments that we have as dermatologists, whether it's topical retinoids, topical combination therapies, topical clascoterone, oral agents like doxycycline, oral antiandrogens like spironolactone, oral antibiotics, or even isotretinoin, I have used all of them together with AviClear, either in combination or in various monotherapy approaches. So that just speaks to the confidence and safety I have of this device and the fact that I don't worry about drug interactions, but I also love the combination aspect that we have in appropriate patients. But this is an example of one of my adult female patients. And for the dermatologists in the audience on this call, you'll immediately recognize what we traditionally and morphologically would call as hormonally distributed acne, because these patients, these female patients, often have this jawline distribution, lower face. It often can be cyclical and varies with their menstrual cycles. And traditionally, we used to use the word hormonal acne. I think many of us have now rephrased that word because when we started once again talking and discussing clascoterone therapy, it was realized that in fact all of acne is hormonal and even male acne is hormonal. So maybe this morphological word is not as useful, but at the end of the day, this is how our adult female patients present. Now, she has already tried some systemic therapies by the time she saw me. She had difficulty with spironolactone because she was getting hypotension even at low dose of 50 milligrams once a day. She has tried a variety of topical agents, but had difficulty tolerating them, sensitivity to BPO, skin sensitivity and burning-like sensation, even with a reduced dose topical retinoids, which she was using every other day. At the time, clascoterone was not available. She used antibiotics by her other dermatologists for several months, did not work, and was not very keen on isotretinoin. In fact, in Canada, probably like in Mexico, we have fairly stringent rules. We need to ensure that they're on 2 forms of contraception. Patient not interested in that, sexually active. And so for all of those reasons, we felt that an AviClear treatment was an optimal choice for her. And she's actually a little bit of a darker skin complexion, which might not be intuitive when you look at her, but she has a Lebanese background ethnically. And so again, traditionally with laser, we have to be a little bit mindful of both post-laser pigmentation, but also post-acne pigmentation that many of our richly pigmented patients can suffer. But this is an example of a 3-treatment protocol. In her case, we utilized a very standard setting of 21 joules per centimeter squared, in according to the typical treatment parameters that I use in my patients. We have discovered that it's really important to maximize the number of pulses. And so initially, I think when all of us were starting to use this device, sometimes in people who had smaller facial features, we would not maximize the entire 300 pulse treatment. And based on that, we've discovered that our success rate was not as significant or is not as high. And ever since we changed the protocol, where I specifically told all of my laser techs, because my practice is delegatable, this procedure, to ensure that they get a 300 pulse count treatment, we started to notice significant improvement and much better efficacy results, which parallel what I'm showing you in the clinical trial data. So this patient did very well. She's happy. In the ideal world, you would consider switching her to a topical retinoid, but I already mentioned to you that she is unable to tolerate it. And although she has done very well even post-laser in this instance, and by the way, my pictures were taken immediately after the third treatment. So unlike in the clinical trial data, I was not patient enough to take a photograph 6 months after the last treatment or 9 months. We did it right after. So obviously in her case, it worked amazingly well. But this is the kind of patient that if you have access or availability to topical clascoterone cream for maintenance-based purposes, you might consider switching her to something like clascoterone. It would fulfill both the criteria of maintenance, it will help with hormonal etiology, and I think it would qualify as good dermatologists because we're combining the treatments which are on one hand safe, but on the other hand very targeted. Now, this young female is an example of someone who has a much more severe acne. And so she actually was appropriately treated by all of the standard acne protocols that we as dermatologists know so well. At some point, she was started on a topical retinoid. She failed that. She was then given a 3-month course of doxycycline in combination with an agent known as Tactopam Forte, which is a Galderma product that combines adapalene and BPO. She failed that. She was given a course of isotretinoin, fairly good dose, approximately an equivalent of an Accutane-based dose of 40 milligrams daily for approximately 6 months. We find that in our city, giving them higher dose than that is just very impractical because they get too much dryness and cannot tolerate it. And then she had a flare after, a significant course of isotretinoin. She was clear initially, and then she flared. And she came with her mother, who said, "We're not doing any more of this isotretinoin, Accutane-based treatment." She was miserable the first time. "Do you have anything else?" And of course, the answer was, "We do. We have laser." But when we think of laser, you might not think intuitively that this patient is going to respond. And yet now I'm showing you a photograph of her after 3 treatments. And in her case, similarly to my other patient, the treatment photographs were taken immediately after the 3rd treatment. So again, this is not after 6 or 9 months post. This is immediately after. And she has a beautiful response with some residual lesions. And although I'm not showing you her photograph subsequent to that, when we saw her 3 months after that last picture was taken, she was even better with minimal erythema. You can see a little bit of background mild scarring, which we have a variety of treatments to use. In my practice, we have all of the laser resurfacing devices. I use skin boosters. Of course, the retinoids can be used as well. So we can target the scarring, but the fact that she had such a profound reduction in inflammatory response is quite significant. Now, if she came to me and she did not have any previous therapies, I might have convinced her, again, if she was just treatment naive, to maybe combine AviClear with even an agent like doxycycline. I have no concern about using it just to kind of dampen the initial flare or initial response and prevents the acne flare from after the first treatment. But that wasn't necessary, and she did so well. The third patient that I want to present to you is unique in many ways. And this is why I'm so grateful that I can speak off-label. So thank you, Caitlin and Cutera team. So first of all, she's not our typical age patient, because I told you that in clinical trials, the patients were over the age of 16, whereas she's 12. So right away, this is already off-label, but I'm comfortable with this because I see a lot of these younger patients. I'm comfortable with lasers, so I had no hesitation. The second difficulty with this patient is that she has dark skin. So you have a young lady with dark skin, but again, I just presented to you the data that the pigmentation tone is not an issue. The third difficulty with this patient is her age. And so you might wonder about tolerability, and I'll tell you how we mitigate tolerability in these younger patients. And the fourth issue, which is always the most difficult, is her father is a neurosurgeon in town, a very prominent neurosurgeon, and her mother is a lawyer. Imagine, this is like the most deadly combination for a clinician when you have both of those parents, a lawyer mother, and you have to talk about off-label treatment with a relatively novel device in their baby girl and what we're trying to accomplish. But yet it's this very same neurosurgeon father who was very adamant about not using any systemic therapy. He said no to antibiotics, no to isotretinoin. She's way too young. He said go for the laser. And that is precisely what we did. Now, in my other patients, if you look at the specific fluence parameters, you'll notice that our treatments were usually 21 to 23 joules per centimeter squared. But again, given the age of the patient, given her ethnicity, in this case, darker skin, we felt that just to ease the treatment protocol, our first treatment fluence is going to be a little bit lower. And that's a practical consideration, which I think is very appropriate. So we started her a little bit lower at 17 joules per centimeter squared. The second thing is, I don't know if you guys have access to this in Mexico, but similar to laughing gas, in Canada, we have something known as Penthrox, which is an inhaled methoxyfluorine. I commonly utilize it for a variety of my procedural-based dermatological procedures, both medical and cosmetic. In fact, we just published a paper on its usability for pain relief. It's an analgesic, but not anesthetic. It's patient-controlled. It's officially kind of utilized in adults, but we can have young teen kids use it as well. And so in this patient, we actually felt very comfortable, again, under following the discussion with the parents. And so that mitigated some of the discomfort. Even though we know that the treatment is tolerable in the clinical study that I just presented to you, on the pain scale of 0 to 10, the average pain score given to the patients with no pain control whatsoever was about a 5, which is reflective in my clinical experience, but nevertheless, we decided to use Penthrox. She did well. For the second treatment, we decided to increase the fluence to 19. And then for the third treatment, we bumped her all the way to 21. But I think what's so remarkable is you can see that essentially all of the inflammatory aspect of acne has diminished. So that by itself is a huge win. And of course, we're happy. This was also taken immediately after the third treatment. The second thing is it reminds us all, and as dermatologists, you guys know this very well, as to why treatment of acne at a very early age is so critical. You know, when parents come in and they say, should I treat my child's acne? The answer is always going to be yes, because even though her acne is maybe not severe, it's mild to moderate according to my scale, you can already see formation of scars. And so that is why it's so critical for us to treat acne and abort any progression of acne. And we know that some scars are reversible. Jerry Tan, one of my Canadian colleagues, has published a variety of studies on this. We also know that you can use now some of the specific topical retinoids. My preference is triferritine or a cleave cream, has the best scar reduction data. We have all the laser resurfacing that she will benefit from in the future. But for now, I started her on a topical retinoid, and we'll see where that takes her. But so important to treat these patients early with whatever treatment access that you have. And I know dermatologists understand this very well. Now, what about combination with other devices? So I showed you examples of my patients. I told you that I'm very comfortable combining it with my medical therapy, but I'm also comfortable combining it with other devices. And so one of the things that we notice in our patients is this persistent erythema. And you obviously have experienced that even in your patients on medical therapy, sometimes you have that erythema while the patient is on isotretinoin. And certainly we see it in our patients as well with lasers. And so this is a young man. He's a competitive hockey player. Even though he's tough and big visually, and he's 6'1" in height, he certainly, like many of my young men, are not very good with pain control. So with him, we had to, on the first treatment, utilize that same Penthrox inhaler that I've mentioned to you. You can see his treatment parameters over a course of 3 treatments. But because we really wanted to perfect his skin, we felt that the use of a vascular device, and we're fortunate that we have, of course, Cutera XLV Plus, would be very helpful to diminish the extent of that mild erythema that he was experiencing. And so similarly to our standard parameters, you can see here at 532 nanometer wavelength, we use the vascular 7.2 joule fluence at the standard parameters. We even decided to improve the texture of his skin by utilizing what in our practice is a Jesner peel. So there was a single treatment with a chemical peel. And so from the baseline, immediately after the third treatment in the middle, and then 6 months after, he's got what I would consider as a beautiful skin with literally minimal scarring, if any whatsoever, reduction of his inflammatory papules, and overall a very, very happy client. So this is an example where you can start bringing the devices that you already have in your practice and certainly combining them. So in summary, we don't have as much time as I would love, but I think at least from a theoretical basis, I've given you a little bit of a context as to why, number one, the wavelength that we're discussing today is the only wavelength that makes sense when it comes to treatment of acne, specifically sebaceous oil glands, and why specifically the AviClear device is so user-friendly, but also so safe by utilizing the contact cooling, the specific sensors to ensure that the pulses are administered properly, and ensuring that the treatment is not only comfortable, but prevents any adverse events. It's a treatment that's very specific and can penetrate all the way to the sebaceous oil gland. It's indicated for all kinds of acne, but also all kinds of patients. So whether it's a severe acne in a dark skin patient or a mild acne in a light skin patient, everyone is a candidate, which makes it so broad and so easy to determine who is your ideal patient. Everyone is an ideal patient. The results continue to improve over time, which is important to counsel on, but also reassuring. And that is what has given it such a long clearance by all of these regulatory bodies. And lastly, not only is it efficacious and not only is it safe, but you actually have a very high patient satisfaction that, in my opinion, rivals all of the systemic therapies that we commonly use in acne. And with that, our discussion of the acne is done, but certainly it's not the end of AviClear discussion, because not only has this device already been used in over 10,000 plus patients worldwide, and I'm sure these numbers continue to be updated with extensive market expansion and education and also peer-to-peer support. But we, of course, are now thinking about other indications. My partner in my practice, Dr. Pullman, is the largest provider when it comes to hidradenitis suppurativa, which dermatologists very well know about. It's a devastating condition that presents with these nodules and cysts, and our patients usually in sensitive areas like axilla, breasts in women, groin area, very difficult to treat. We have all the biologics in Canada, including secukinumab and now also adalimumab was the initial one, secukinumab, and now bimekizumab, all these biologics, but very difficult to treat. So there's a lot of potential and preliminary studies that this device could be used for those patients with HS, because they still have the same origin of sebaceous oil gland. And of course, a very common condition that I see almost on a daily basis in our patients, sebaceous hyperplasia, where they present with these umbilicated papules, usually on their facial areas. Again, there's a possibility of using AviClear for that indication as well, especially because it does provide you with an option of a smaller spot size, but studies are currently underway, and we'll see how efficacious of this. But certainly the future is bright for this device, in my opinion. And with that, I'm done kind of the formal part of my presentation. I'm open to any questions that you guys might have for me.
Si gustan hacer alguna pregunta al doctor Andrei y lo vamos respondiendo, puede ser en el chat o también abriendo sus micrófonos. Adelante, doctores. Creo, Víctor, tú tienes el chat, ¿no? Abierto.
Sí, aquí, bueno, la doctora Ingrid está agradeciendo, pero sí, tal cual, si tienen alguna duda, por favor, pónganla y la podemos resolver. Aquí el doctor Jorge Lauro hizo una pregunta. Doctor Andrei, Dr. George made a question where it says, have you seen any common ground on non-responders?
Yeah, so it's a wonderful question because, of course, we try to predict the patients who will respond and similarly who will not respond because we don't want to waste anyone's time. It's a combination of several factors. So I would say the following. The patients who actually have the mild comedonal acne sometimes can be the toughest to treat because they only have the comedone involved. And so those patients who just have like a little bit of like whiteheads or a little bit of blackheads sometimes are more difficult to treat than the patients with inflammatory acne. And as you pointed out, or as I've shown you on the slides, it's really the inflammatory lesion count that was studied specifically in the clinical studies. So in this case, the inflammation within sebaceous oil gland works really well as a target. But similarly, if you have minimal inflammation, those patients with comedones, I think, but sometimes the response might be a little bit less impressive. So that's one type of patient that I've noticed. The second patients are the patients who maybe have failed everything already. And while I've shown you examples of some of those patients that have done very well with AviClear, sometimes, if you have a patient that's even more severe with nodules and cysts, I think if they haven't tried isotretinoin with nodular cystic acne, in some of those instances, you have to consider both the medical therapy and device therapy. But for various reasons, even nodular cystic acne patients might be more inclined to do the laser. And I think as long as you educate them on the success rate, then you will notice that as well. The third aspect is, and perhaps that's reflected in your question, is what proportion of patients need a touch-up? Because, as we all explore these treatments, you cannot have a 100% success rate. And so I would say that in my practice, about 10% of our patients maybe had a mild to moderate improvement, but maybe not 100%. And so in those 10% of patients, we sometimes offer a fourth touch-up treatment. And speaking to our colleagues who are other global KOLs throughout North America, in particular my US colleagues, I find that I've heard a similar response from them as well. So although that's a small proportion of patients, I think it's always useful to be prepared to consider a little touch-up treatment in those guys as well. But I would say those are kind of my main themes about the non-responders.
Thank you, doctor. We also had a couple of questions, from emails and social media from some doctors that are interested. Like, what are some learnings and best practices from your experience?
Yeah, so I think, in my practice, again, because it's a delegatable procedure, and initially, as a clinician, as a dermatologist, I make sure that I standardize all of this. I have very experienced team. Some of them have been with me for over 15 years. And so initially, when we just started a couple years ago doing the treatment, I noted the discrepancy between my senior laser tech, who has been with me now for 16 years, and my junior laser tech. And then we tried to analyze it because naturally, you want to make sure that everyone benefits from the best practices. And as I already pointed out during my presentation, my junior laser tech, in the event of patients with smaller facial features, was not utilizing the maximum number of pulses per patient. And so I've realized that it's very critical to ensure that every one of your patients during the treatment gets a 300 pulse approach. So that's number one. Number two is pain control, right? Like, and so pain is really important. It's a tolerable procedure, but certainly some of the patients will notice that it's a little bit uncomfortable. And I think Cutera has done an amazing job of utilizing the contact cooling and all of the things that I've already mentioned to you, but it still can be a little bit uncomfortable. So if you have little tricks in your practice, whether it's like me, availability of Penthrox, or maybe instances where you have access to laughing gas or other modalities to kind of mitigate some of the discomfort, I think it would be helpful to have them because we have a variety of patients. And if you have those patients with sensitivities, they'll just improve their ability to tolerate the patient and ensure that it's successful. And number three is being open to the idea of combination therapy. And I think for the dermatologists in the call, that's what distinguishes clinicians from maybe other providers who do not know dermatology as well, do not have access to those treatments. And so there's nothing wrong, in my opinion, of combining treatments because, again, we're not doing a clinical trial. We're treating patients and we're trying to make sure that they have the best possible outcome. So in my practice, I would say most of my patients are actually given an option of using, at the very minimum, a topical acne agent just to mitigate the inflammation, this discomfort. And I've mentioned some of them, but you could utilize clascoterone as a kind of as an accessory step because it's so good at being well tolerated. That's the Winlevi cream, or being able to mitigate some of the inflammation. I started using it with isotretinoin as an aside, but I also use it with laser. Or in patients who have a little bit of that scarring and a little bit of inflammatory response, there's nothing wrong with combining AviClear with a topical combination of retinoid and one of the anti-inflammatory agents like BPO or even a topical antibiotic. And in some instances, we even use systemics. So I think it's not one versus the other treatment. I think it's being able to combine all of them to ensure that you get the best possible outcome. So those are intuitive but very useful, I think, tricks. And if you follow those steps, I think your patients will do very, very well. But it's surprising, from a patient standpoint, how many of our patients want the device-based treatment. I mean, even as a dermatologist, when I see other conditions like vitiligo or moles or whatever it is, and I'm sure you guys are like me, you might have the best medical solution, but the patients say, doctor, don't you have a device for this? Don't you have a device to treat my vitiligo? Don't you have a device to treat my moles? So it's so natural for them to say, don't you have a device to treat my acne? And the fact that we finally have a device is a very elegant discussion that comes into play with all of my patients.
Thank you, doctor. We have another question from Dr. George. He's asking, how frequent does your personnel have like wrist pain from frequent treatments, and how did you solve it?
Sorry, I don't fully understand the question.
That
It's
if
about pain.
your personnel from the clinic.
Can I make it?
Yeah, sure.
The thing that the thing when I had the equipment at my clinic,
Yeah.
it was somehow difficult to turn or manage the probe of the laser. And some of my personnel complained later that they got pain on the wrist, the
Oh, I
nurses.
see. Oh, interesting. Okay,
So
okay, so, I mean, that's a valid concern, and I assume your staff are well versed when it comes to like laser devices in general. Would you say? Like, do you guys have a number of lasers available in your clinic?
yeah, sure.
You do, yeah. Yeah, I mean, like I can't say that we do 10 treatments a day with AviClear, but we certainly use it daily. And so like, my staff, they're doing exclusively laser treatments all day long. Like all of our lasers are just working. So I haven't really had that question asked before. So I'm not sure in terms of like just ergonomics difficulty, but I don't find it's necessarily any more difficult to administer than, for example, laser resurfacing like CO2 laser or any other pulse-based treatment. So
What? Hmm. Yeah,
yeah.
this is because this is the most heavy handpiece that we have managed before.
Hmm.
This is the heaviest, even
Yeah.
though it has a support. But I think with time, they will find a way to get
Like make it a bit lighter.
solve it.
Yeah, it's a valid question. So I don't have all the answers pertaining to that. So thank you for raising it. All I can tell you is my staff are pretty much all women. I have a couple of male physicians like myself, but our like laser techs are all women, and they're quite small women. So they're not certainly they're not power lifters. So they're tiny little ladies. But yeah, like I guess I haven't really had this mentioned to me in the past couple of years in my practice, but that's a valid question. Maybe for the company, if they have any tricks in terms of ergonomics.
Yeah, sorry, it's Caitlin from Qterra. I'll just provide just a bit of context. One of the things that we've seen help during a treatment, just even for, overall kind of ergonomics, is making sure that the provider that's treating is actually sitting at the right height. So you have a little bit more control and influence on the handpiece. So you're kind of controlling the handpiece versus the handpiece trying to control you. So I would maybe suggest looking at the height at which they're sitting, if they are sitting, or standing, if they can kind of go between the both of them. Otherwise, to Dr. Metelitsa's feedback, we do have practices that do 20 plus treatments every couple days, and they don't have any complaints as far as the ergonomics or the provider experience.
Thank you.
Yeah, thanks, Caitlin.
We have another question that this could be helpful for doctors here in Mexico. It says, what marketing did you do in your practice to drive awareness of AviClear?
Yeah, so that's a great question. So, I already mentioned to you that like in our practice, we have a lot of medical patients through referral. But what we do is every single patient, even if they're referred for AviClear, we still mention to them the availability of the device, right? So if you have a referral-based practice, in addition to your cosmetic-based practice, I think it's nice to educate them. And so, when they come in, when a parent comes with a teenager, number one is they might not necessarily expect to suddenly do the laser, but you kind of plant a seed, and maybe they'll try something else initially, or maybe they won't. But eventually, many of those patients who start with a different therapy end up being an AviClear patient. So I've learned not to judge them. That's number one. Number two is like with any device, I think as soon as it becomes available, and this is on the cosmetic side of the practice, I think you need to build the hype. And so based on that, I think you need to immediately, as soon as the device is available, treat several of the patients, or if any of your staff have acne in this case, or maybe patients that you have access to. Because as soon as you have your own success story or your own patient cases, I think it's so easy to market it. Initially you have to rely on the companies, but I showed you some of my patient cases. When I show to other patients that this is, someone who is similar to them and I've treated them, I think it resonates very strongly in terms of marketing. And so they do very well. And then, of course, you might be one of the first in your city or in your surrounding area who has this device. So if that's the case, like it is in my practice, then we immediately contacted many of our colleague dermatologists, and we said, hey, like if you have any patients who have acne, who have failed other therapies, or who are interested in treatment, then send them my way because I have access to the device. And interestingly, even colleagues who don't necessarily refer patients, derm patients, when it comes to laser, if they don't have access to it, they will send them to you. And so you could be that default provider for all of your colleagues around. So I think those are like some marketing strategies. I mean, obviously, there's other forms of advertising, and I think this is where Qterra can also help you find the best possible solution, handouts, and things like that.
Thank you very much, Dr. Andrei, for your time. Just listening to your experiences, it's awesome to have you here in our webinar. and looking forward to do different collaborations. It will be my pleasure. And thanks again for your time, for your support, Caitlin, Matthew, Martin, and see you soon.
And equally, once again, thank you so much for spending your evening with us today. And I hope that this was useful. And I look forward to, at some point, meeting you guys in person.
Muchas gracias a todos. Que tengan una excelente noche y estamos en contacto. Muchas gracias.